Media Relations team. I have for you today Dr. Adnan Munkarah and Mr. Bob Riney. They're going to answer your questions of the day. But first, they are going to brief you a little bit about the situations in our hospitals. We do have some news about a federal team coming to Wyandotte and also a blood shortage that we'd like to speak with you about. If you are going to have questions, go ahead and send me a message in the chat or raise your hand virtually. I'll do my best to call on you in the order in which I see your questions. And with that, I will turn it over to Dr. Munkarah, who's going to get us started. Adnan.
Thank you, Dana. Good morning, everyone. Thank you for being with us, and I hope all of you have been staying well. I would like first to start this morning by addressing a totally different topic than COVID, which is the national blood shortage. The blood supply is at one of its lowest levels in recent years. And if it does not stabilize soon, we are very concerned that life-saving blood that is needed for patients with certain illnesses and diseases is not going to be available to help in the care of these patients. And this is according to 3 national blood organizations, including the American Red Cross, American Blood Centers, and the Association of Advancement of Blood and Biotherapies. So this is not a specific problem for one blood organization, and this is not only specific to us at Henry Ford. In fact, we've been dealing with this now for many weeks, if not months, and it has been exacerbated recently. People are asking what's causing that. Usually in the first month of the year, we do see a decline in blood donation, but it has been exacerbated now by the pandemic itself, which has caused declines in donor turnouts, blood drives being canceled, and staffing challenges. We are ever grateful to our phenomenal team and our blood bank team at Henry Ford Health System. They have been managing our blood supply on a day-to-day basis, feeding all our hospitals, infusion centers, and ambulatory surgery locations where blood is needed. Like other hospitals, we've been under significant pressures, and our team has been managing on a day-to-day basis, sometimes within 24 to 48 hours with some blood groups. While we have not canceled any surgeries, we just bringing that up because if things do not change over the next few days or few weeks, we are very concerned about the impact of blood supply on the care that we provide for certain illnesses that necessitate blood and certain procedures. Our ask to the community is please step forward and proceed with blood donation. Anyone who is 17 years or older and is eligible, the process will take about 1 hour. 1 pint of blood can save up to 3 lives. So it does make a significant impact on the lives of our community and our loved and sick ones when they need blood. We have 2 critical blood resources where people can sign up to donate: www.versity.org/give or www.redcross.org/donate. And I'm sure Dana will be putting these on our chat box. I'm going to shift now to our COVID status. As of this morning, we have 520 patients hospitalized with COVID across our hospitals. That's about 10% increase in the past week. And we have shared with you past week that we have had an increase compared to the week before. So we are still on the surge and we are on the rise at the present time as it comes to COVID hospitalizations, similar to what we have seen in the community with respect to COVID patients. We also have 5 children under age 17 who are currently hospitalized among our hospitals with COVID. Our test positivity rate continues to be high. We are 36.7% this morning. So this is significantly high, compared to where we were at our lowest in the early summer, where it was in the single digit. And, one of the things that is most concerning that people who are presenting with symptoms, whether to the emergency department or outpatient facilities, the positivity rate is about 50%. This means 1 out of 2 people coming in with symptoms suggestive of COVID are testing positive for COVID. Last week, the highest COVID positivity rate was among people ages 21 to 30. And we are seeing it among our community, among friends and families. This is not impacting elderly people only. It's impacting children as well as impacting people in the young age group. In fact, people in the age group of 21 to 40 represented 33% of our positive cases in the past week. So 1/3 of the cases testing positive are represent the younger population. As far as those people who are hospitalized with COVID within our hospitals and within our system, the majority remain to be unvaccinated. So over 65% of patients who are within the hospital are the unvaccinated group. When we look at people who have had boosters versus those who have not had boosters, over 90% of patients who are in the hospital have not had their booster doses. And the same stands for people who are in the intensive care unit or the ventilators. So it is very clear that people who have not been vaccinated and or have not been boosted when they've been vaccinated are at a significantly high risk. And this is data that is consistent not only in our system, but across the state as we talk to our colleagues and other medical experts across the state, and also it's across the nation. This is a trend that is very, very similar to what we are seeing across the nation. And this is why we cannot stress enough the importance of vaccination and the booster for those who are eligible for keeping you out of the hospital. And we keep seeing the misinformation related to vaccine, lack of efficacy of the vaccine. And it is honestly getting more and more frustrating. The data is mounting. The evidence is extremely strong. This is not evidence only in our hospital. This is not only in the state. This is around the nation and around the globe. Experts have looked at the data. Many people, hundreds of scientists, of physicians, of infectious disease experts have looked at the data and have shown that people who are vaccinated, even when they get an infection, tend to be less sick than people who are not vaccinated. The booster has definitely minimized the impact of COVID. Even when people are getting an infection, it is very mild. So this is why the vaccines continue to be important. They're being proven to be extremely safe. And I know that people are getting fatigued of us repeating that, but this is our way out. And everybody is repeating the same and confirming this. This is not only one physician. This is not 10 physicians. This is hundreds, if not thousands of, in fact, thousands of physicians around the globe and experts who are supporting that. The last thing I want to kind of touch on is also to kind of remind all of us that we are also through the flu season. And we need to get our flu shot at the present time to make sure that we are combating both flu as well as COVID. Our flu positivity rate luckily continues to be low. It is less than 1%. And we have not seen any cases so far who has both COVID and flu, at least in our hospitals. I'm going to turn it over to Bob Riney now. Bob?
Good afternoon, or good morning, everybody, I guess. I'll start off by just expressing gratitude that we are thankful for the opportunity to have a federal disaster medical assistance team providing support at Henry Ford Wyandotte Hospital. They arrived on Sunday, January 9th for orientation and started providing immediate care for patients on Monday, January 10th. And they will be on site until Friday, January 21st. Unlike prior surges, Henry Ford Wyandotte Hospital's emergency department is receiving an extremely high volume of non-COVID patients, as well as a pretty significant resurgence of COVID-19 cases. DMAT has provided significant relief and support to all of Henry Ford Wyandotte Hospital, especially our nursing and medical staff, while working seamlessly with our team to provide the safest and best care for our patients and for the Downriver community. We are equally grateful for the medical support coming from the U.S. Department of Defense to provide further support and relief to our team at Henry Ford Wyandotte Hospital. This is the second phase of a two-part deployment under the U.S. Department of Health and Human Services and the Department of Defense Medical Disaster Deployment Group. The first phase is a HHS DMAT medical civilian deployment, followed by the Department of Defense medical deployment. Similar two-phase developments have occurred at other Michigan hospitals in recent weeks. They have the expertise to support us in up to providing care for 24 beds, as well as providing support on additional inpatient and surgical patient units. And we are very grateful for that. As of Monday, January 10th, we have 87 beds that are closed due to staffing challenges. This includes 64 at Henry Ford Hospital, 22 at Henry Ford Wyandotte Hospital, and just a few at Henry Ford Allegiance Health in Jackson. This represents about 3.6% of our total beds across the health system. The number of bed closures fluctuate, as I'm sure you can appreciate, depending on conditions that we monitor on a daily basis. Last week, that number was 97 beds closed. And as we've talked about in recent briefings, we monitor conditions daily and make adjustments if needed. This involves balancing patient volumes, staff shortages, and the extra stress and pressures that come with COVID patient care, along with non-COVID services, with a focus on always maintaining the safest environment possible. Emergent care and treatment for serious illness and conditions, including trauma and life-saving procedures, is available as always, 24 hours a day, 7 days a week. Critical or time-sensitive surgeries such as cancer, other tests and procedures are not being canceled or delayed. Non-time sensitive procedures that are postponed because of the elements that I described earlier are being rescheduled as more beds become available. One of our challenges, and the challenges of all health systems, is the positivity rate within our own team members. As of today, 593 employees are out of work due to COVID. This is due to the fast spreading Omicron in the community. These are not work-related spread. The continuous spread of COVID not only puts a strain on health systems because of the number of patients that we see, but it continues to expose our frontline healthcare workers in getting community spread when they are not wearing the PPE that they are wearing inside the healthcare organizations. So this is a dual pressure from both the increase of patients in our community and then the increase of infectivity in those that we rely on to care and take care of and treat patients in our community, which is why we continue to be so concerned about all doing our part to maintain our vigilance and to manage this pandemic. Finally, we continue to implore the community to be part of the solution, as Dr. Munkarah stated. This is up to us and our behaviors: getting vaccinated, getting a booster, mask wearing when in public settings, and other prevention strategies we know will not eradicate. We're not suggesting they will eradicate, but they will minimize the pressure points that we are feeling both as a community and as a health system provider. With that, I'll open it up to questions for Dr. Munkarah and myself.
Thank you, Bob. Folks, go ahead and put your questions in the chat or raise your hand virtually. I'll do my best to call on you as soon as I see you or in the order in which I see your questions. Our first question is going to come from Lynn Peterson. She's with Trends in Medicine. And Kristen Seamus, I see your hand up. You'll be next.
Hi, thank you very much. First, the good news, and that is that I am actually been very impressed that you have been doing this weekly for months. And the other major health systems don't do it, and it would be very useful if they did. So that's the good news. A couple of weeks ago, I asked a question and didn't really get an answer. So I followed it up with an email, and I was told, no, we're not going to tell you that. And I was a little startled by that. What I was asking is for more information on the patients who are hospitalized. Did they have antibodies first or antivirals first? Did they not have access to them? Are these immunocompromised patients? Are these overweight patients? Are these comorbid patients? You know, tell us more about who these hospitalized patients are. So I'll ask it again.
Lynn, I'm sure you understand that there's a limit to the amount of data that we are able to provide based on HIPAA factors. I will go ahead and let Bob and Adnan weigh in as they see fit, but you have to understand where we're coming from in terms of protecting our patient privacy and also managing to do the work that we do, which is very detailed on a given day.
So Len, I can give you some, I don't have the exact numbers in front of me, but we look at general data on a regular basis. So first, with your respect to your questions, we have repeatedly looked at people who are unvaccinated versus vaccinated, and we've shared, we are able to share with you the number of people who have been vaccinated versus unvaccinated. The general average has been about 65% of people have been unvaccinated, but we can get you the exact numbers, in the past couple of days in that respect. With respect to your question, whether these people are people who have had comorbidities, we've looked at our patients who've had vaccinated versus unvaccinated with respect to these comorbidities. And what we looked at based some scoring system, we looked at people, how sick are people or what kind of comorbidities, other illnesses they have before they contracted COVID and got admitted to the hospital. And it is very clear that when you compare the vaccinated to the unvaccinated, people who are vaccinated have started with a higher level of comorbidities, means that they have been more predisposed to have an infection and be sick than those people who have been vaccinated. And again, this is a kind of what we call acuity scoring index. We are happy to share it with you. It is hard for people who are who do not understand how that acuity index works to understand if we give you a number of 3 or 4, but we can tell you that we constantly look at that. You asked a question regarding monoclonal antibodies and antivirals. With respect to the monoclonal antibodies, we have definitely seen that the monoclonal antibodies do decrease the risk of infection and admission to the hospitals. We have continued to give this, but we have recently switched from giving the prior regimens that we have, the Regeneron and the Eli Lilly product, because they are not seen to be effective against the Omicron. And we have switched now to what we call the Sotrovimab, which is it's a product that is produced by another company that seems to be more effective against the Omicron. And we started that over 10 days ago. And the reason we decided to make that switch is to make sure that we are giving those effective medications. With respect to all other antivirals, the only ones at the present time that have been shown and approved to have some efficacy is remdesivir. Remdesivir does not have, at the present time, an indication to be given in the outpatient setting. They are starting to allow that, but there are still both billing, insurance, Medicare kind of restrictions of whether you can give it in the outpatient setting, and we are working to see whether we can give it to those people. And it has some efficacy, but not the greatest. With respect to the other antivirals, the 2 medications, the pills that have been made available now, which are Paxlovid and Molnupiravir. These are by 2 different companies, by Pfizer as well as by Merck. These are not available to us in our hospitals yet. However, we have set guidelines to prescribe them. So our physicians at the present time have a way to prescribe them through orders, and they are obtained usually through Myers Pharmacy. Myers has the first they've had the first shipment of this, and we are hoping that they will decrease these numbers, but it is very early to kind of conclude anything because these literally became available last week. I hope these addressed some of the general comments, and again, with respect to comorbidities, we can give you some percentages. I can work with Dana and our team related to that.
Thank you very much, Adnan. I appreciate you. Okay, next we have Kristen Seamus from the Free Press, then Dustin Dwyer, then Rami from Reuters.
Thanks so much for taking my question. Really appreciate it. I wondered if you could detail for us a little bit more about the new team that is coming from the federal government, when it might arrive, how many people are coming, and how much relief they might be able to provide to the hospital.
They'll be able to provide, Kristen, hi, this is Bob. They'll be able to provide support for up to 24 inpatient beds. So that is something that we're extremely grateful for. But the details of that plan are still being worked out and will be communicated by the Department of Defense.
Thanks, Bob. Would you also like to address the fact that these folks are helpful and more than welcome, like a million times welcome, but we still are under a lot of pressure here. So don't see these folks as, eliminating all our problems altogether.
Well, there is not a silver bullet solution, as I think all of us appreciate to this. We have, systemic challenges with just incredible volume and very, very tired medical practitioners, and of course vacancies that we are working to fill, and that is true of all health systems that have been in the middle of this surge. So this is what I would call a real help in terms of it does add meaningful clinical capacity, but it's also a mental boost too. It is a great sign of hope, optimism to our care teams that they're not alone, and that support as needed is coming. So even our care teams know it doesn't begin to solve problems, but it solves some. And that is not only a real benefit, but it's also a producer of hope, and that's important.
Thank you, Bob. Okay, Dustin Dwyer, Michigan Radio, go ahead.
Yeah, hello. This is a question we just kind of have to ask every week, but are you seeing any signs that patients who have Omicron are getting less severe cases of the virus or less severe disease than you saw with Delta?
So, Dustin, I can speak to what we are seeing in the general public. So first, to clarify how do we detect whether people have Omicron? This is something where genotyping needs to be done. Genotyping meaning looking at genetic composition of the virus after we are able to collect it into specimens from patients. And this is most of the time done at the state level, and sometimes the state send it to outside labs. Last week, the state was significantly limited because they had problems in their staffing within their lab to do enough genotyping to give us an idea about the number of people who have Omicron and versus the people who have Delta. We know that we continue to have both Omicron and Delta at the present time in our community, also among our patients. What I can tell you, if you look at the number of people who are turning positive into the community compared to the number of people who are in the hospital at the present time, the relative numbers are definitely lower than what we have seen in the summer, meaning the total number of people who are in the hospital compared to the number of people infected in the community. So which is telling us that the disease at the present time is not causing as much of an acute illness. The problem, however, that we are dealing with, that the number of people in the community who are infected way outnumber what we have seen in any prior surges. So the denominator, the total number of people in the community is much larger. And this is why we are continue to seeing this significant rush to our hospitals. And this is why we continue to have patients in the over 500 patients with COVID within the hospital. So it's a ratio problem. We have a disease that is a virus that is very infective, that is transmitting a lot. It might not be causing acute illness in as many people or severe illness in as many people, but it is still the small percentage where you have it is causing that are filling the hospital and causing what we are seeing at this point.
Thanks, Adnan. Bob, anything to add there?
I just want to double down on this point because we all hear out in the communities, the reaction that for many people, Omicron is affecting them in a mild way. And then they question, so why are the hospitals full? And so what Dr. Munkarah just shared is really important. Of any of the variants, this is the most contagious. So the number of people being infected is so big. So even if you have, excuse me, even if you have a small percentage of a very big number requiring hospitalization, it puts incredible pressure on health systems, and that's what we're seeing. And so I think it's an important point that is getting somehow lost in the narrative.
One more thing, Dana, I want to add, because this is, again, extremely important to reinforce. People say, well, it is like the flu. Well, even if it's like the flu, we lose people to the flu. People die from the flu when it gets severe, because there are a certain percentage of people who get severe flu. And now the numbers of COVID patients who are infected with the Omicron is multiple fold what we see with the flu. So this is the concern. The concern is that we have a huge number of people, and although the percentage of people who get sick or might die is much smaller, but the total numbers are much bigger. So we are going to see, unfortunately, a bigger negative impact, a bad outcome if we don't control it.
In that vein, can you address the idea that folks are like, well, there's a lot of Omicron out there throwing up their hands, I'm going to get it. And, what use is it to try and control this, try and control it or avoid it? What do you say to that?
So I really think what we need to think about is that, yes, there is a lot of Omicron there, but it does not mean that we contribute to kind of causing more cases out there. What we need to do is continue to use all preventive measures so that we can stop that spread that we are looking at. As we look at the present time, we continue to be on that rising curve. The numbers continue to go up. The patients getting into the hospital continue to be up. This means more people are going to get sick. This means more people might die from it. It means that we might transmit it to more people who are immunocompromised in that respect. And what we need to do is continue to take the measures to decrease that impact so that we can get to a point where we are able to flatten the curve and get back on the declining limb of that curve, where we have less and less people infected and less spread in the community. People thinking, well, let's let it kind of spread like wildfire and we'll get herd immunity, are not looking at the potential negative impact, the people who will get very sick and might die, the impact on people who do not have COVID, who cannot get care because we are so busy at the present time taking care of COVID people, because our staff are out with COVID.
Thank you, Adnan. Okay, next is Rami from Reuters, then Ali Gross, then Corey Williams. Rami, go ahead.
Thank you, Dana. Mr. Riney, you mentioned that the federal teams are supposed to finish their mission with you guys on January 21st. That's only about 8 days from now. Do you feel that that really allows them enough time to have an impact? And do you wish that perhaps they would extend or offer more support?
Rami, thanks for that question, because I do want to clarify. The first phase is through January 21st, and then the second team, phase 2 that I referenced, will come for an additional 30 days. So we are looking at 45 days of total support, and that has a much more meaningful impact.
Wonderful. Thank you for clarifying that. Appreciate it.
And while we're on it, Corey Williams' question is related to that. So Bob, can you clarify, there's 2 teams. So like there's the 8 team, or we'll call them Chestnut team and Elm team. So like it's 2 different teams, not like we're growing the Elm team, correct?
It's 2 phases of support, one coming from HHS and one coming from the Department of Defense in a highly coordinated way. They're not overlapping, they're complementary. So it is 2 phases. And I saw another question in the chat about why Wyandotte versus one of our other hospitals. And what I would share with you is that we submit the current situation and data to HHS for all of our hospitals, as the other hospitals do, and then they are making a determination based on where they believe they can have the greatest impact. And certainly at the time that they looked at our data, as I indicated earlier, Wyandotte was and continues to be extremely pressed with very high COVID related hospitalizations as well as others. And so they make that determination, but I think it's grounded in what they're looking at in the numbers.
Thanks, Bob. Okay, next question is from
Can I
Ali
just
Gross.
quickly follow up? I'm sorry,
Oh, sure,
Dana.
go ahead.
So Mr. Riney, you said an additional 30 days from the 21st of January, basically. So is there an end date then of like February 20th for the second phase?
I don't know the specific end date because we haven't gotten that. I'm basing the 30 days based on other experiences with other systems. I would assume that they are looking at what the conditions will be in various markets and their ability to deploy. Obviously, we welcome and are grateful for any support that we have, but based on what we've seen, that would be the general timeline we'd be looking at, Rami.
Okay, thanks. Sorry about that.
Okay, next up is Ali Gross, WXYZ. Go ahead, Ali.
Hi, my name's actually Kiera. I need to switch that. I'm Kiera with WXYZ.
Hey, Kiera.
Hi. But just following up on that, you said you submitted all your information to HFHS. Do you know when that information was submitted, when it was determined that we would get federal aid? And do you see other hospitals in your system needing that help in the near future?
So I don't know the date of when it was reviewed or submitted. You'd have to get that from HHS. I think if you talk to any one of our hospitals, they would tell you that they would welcome external help because everyone is feeling pinched in different ways. But the reality is we're grateful that we have support in any part of our system, because then that allows us to use some of our other internal talent in other places in the organization where need is strong as well.
And one more question. I know you said you haven't had to cut back any surgeries because of the blood shortage, but do you see that happening in the near future? And what other ways is the blood shortage impacting Henry Ford?
We continue to look at that. We've not yet had to do that, and we are managing it on a day-to-day basis, but we are concerned, as we have mentioned earlier, because of the fact the month of January tends to be a low month to start with, even before what we have lived through. We are very concerned that we might get to a point where we might need to cancel surgeries. The team does that. We get on a day-to-day basis inventory of where we are with respect to the numbers. Our team looks at that, in fact, the day before to determine what are the surgeries that we have, whether there are any specific surgeries that might necessitate or need large volume of blood, and adjust accordingly. We are keeping our fingers crossed. We've managed so far. We are bringing that up so that seeking the help of the community and people to step forward and donate blood.
Thank you.
All right, Corey was last on my list, but he says his questions have been answered. So if anybody else has a question, go ahead and raise your hand, speak now or forever hold your peace. For our friends who can make use of video, we do now have some video of the DMAT team arriving at Wyandotte on Sunday. So email me very quickly. I'm going to put the email address in the chat for you, and I will get that to you before I log out and head to the airport. The rest of the media relations team is here to help you, though, if you need it. Bob and Adnan, anything to add before? Oh, Lynn has a follow-up. Lynn, go ahead.
Thank you. I wasn't trying to be argumentative about the profile of these patients. What I'm trying to get at is, are we primarily hospitalizing patients who are immunocompromised or patients who fit a certain profile? Or is this broad as it was in the early days of Delta?
Lynn, I think we have two popular, this is an excellent question, and it is very valid question that we look at on a regular basis. Honestly, it looks today that we have two populations that we are dealing with. Among the vaccinated people, the majority have, as you have mentioned, either are immunocompromised or have some underlying medical condition that put them at a risk to develop a severe infection and need to be hospitalized. The unvaccinated group, on the other hand, is a totally different group. We are seeing people who are healthy, who have no significant medical condition, who are younger, who are in their 30s, might be in their 40s, who are hospitalized with acute illnesses. And this is what is concerning us, that kind of dual population, that the younger population, the people who are not that sick, we are still seeing that, who are not sick before they get COVID, we are still seeing them get severely ill with COVID and being on the ventilator. And as we have said before, this has bad implications on the long term sometimes for these patients, and some of them lose their lives. So yes, there are two populations we are looking at, and they are mostly divided on the vaccination status.
Thank you. That's really where I was trying to get at.
Yeah.
And I appreciate that profile because it's very helpful across the country, not just locally, because we're not getting good pictures of that. So thank you.
Well, great. Well, I'm glad you had that follow-up because it bought me a little bit of time to let you all know that we still have yet one more hoop to jump through on the HHS video. So once we do that, we will get it to you. I do see some emails coming through, so I will make sure that someone else on the team follows up. With that, I'm going to wrap things up for the day. Thank you, Bob and Adnan, as always, for your leadership and for taking the time to brief our friends in the media. And thanks, everybody, for joining us.
Thank you.
Thank you.
Have a great afternoon.
Bye-bye. Stay safe.
Thanks, Bob.
Thanks, everyone.